My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. Welcome to this episode of Operate with Zen. Today, I have the great pleasure of being joined by Dr. Tait Shanafelt. Tait, introduce yourself to the audience.
Great to be with you, Phil. I'm a hematologist oncologist, chief wellness officer, associate dean at Stanford School of Medicine.
Yeah, so today we're going to talk about wellness and burnout and a variety of things, and we're going to talk at it at the institutional level, but I would love to start at the individual level. So give us a little bit of your personal story and how this journey started for you.
Yeah, it's a bit of serendipity. Really began for me when I was a senior resident at the University of Washington and leading a team with more independence than our residents probably have today, and just watching the interns on my team struggle, really having a front row seat to their experience, and just seeing the way that they would talk about patients, react to that 5 a.m. admission right before they handed off the pager, and really remembering having some of those same experiences and feelings being so close to it. And I was about to begin a research elective and had a wonderful mentor, Tony Bach, University of Washington. And so we were planning what we were going to work on. And I said one of the things I wanted to study was the experience of training. And Tony, being a great mentor, just asked a lot of questions, what I was observing and what my hypothesis was. And he said, I think what you're describing is burnout, but why do you care? And said, because it's not only impacting the residents, it's impacting our patients. And so he helped pull together a team, and we did a study 22 plus years ago that really was the first study to show a link between occupational distress in physicians and quality of care, patient outcomes, and really just became a lightning rod, and a lot of lay press coverage and the like. And I had transitioned to Mayo to start fellowship when it had come out, and some of the educational leadership at Mayo said, we really like this line of research. Would you help us set up a study here? And so we set up a longitudinal study in residents that it went on for over 15 years. And one thing led to another. I started having national societies ask me to lead studies for them. Some of the early ones actually were mini surgical societies, Phil, Society of Surgical Oncology, American College of Surgeons. And one thing just led to another, and there was some serendipity there. We had a chair of medicine retiring at Mayo Clinic in 2007 and came to me and said, I like this research you're doing, and I'd like to create a center and really approach this from the organizational level. And would you tell me what you need? Because I'd like to establish it as a sort of legacy gift from me to the department. And so that sort of led to us establishing our first center at Mayo and starting to look at system factors, organizational interventions, and the like.
It's a really fascinating story from many perspectives, but somehow just, careful observation of the clinical circumstances we're in can really lead to tremendous satisfaction in our future careers.
Yeah, I think that's right. And on one level, I think so much of what we were seeing are things that all of us witnessed, experienced during training. It's sort of house of God type things that we've all known about. And I remember actually, I've told this story a few times, but I was a first-year fellow on the shuttle bus between our two hospitals at Mayo Clinic, and was riding on the bus when the day our study came out, and Paul Harvey came on the radio on the bus and says, study from the University of Washington shows resident burnout leads to medical errors. And I remember it was sort of this crazy experience, like that's our study that he's talking about. And, I really caused a lot of reflection of here was an unfunded study led by a resident that was galvanizing this national conversation and about things, again, that we knew. Why was that the case? And it occurred to me it was really because we had done two things. We had studied it in a methodologically rigorous way, and we had drawn connection to patients and care quality. And that those two things were what really elevated this to visibility. And for the first 4 to 5 years, that's really what our research team focused on, was really dissecting all the ways in which this was impacting the healthcare delivery system. And as that evidence became stronger, we could start turning our eye toward what do we do about it.
I love it. And so just kind of for the audience, when you talk about this now, what are some of the medical errors, the specific things you bring up to kind of provide context here so people understand these things?
Yeah, so now I think when we consider system or delivery system outcomes, we often think in sort of 4 areas. We think about errors in quality, patient experience, productivity, and turnover. And so from the patient experience dimension, there's strong evidence on prospective longitudinal studies looking at your burnout score today, predicting unsolicited patient complaints over the next 1 to 3 years. As every 1 point as your score goes up, the risk of patient complaints goes up. The care quality outcomes that have been looked at are really diverse. That's always a hard domain to study, as you know, could I really pick out the week in which Phil's care quality was lower out of the last 52 weeks? Probably not. Could I identify in a chart every imperfection in the care? No. Could Phil identify that? A much better chance that you would see it. So the studies that have looked at just your report of medical error that have harmed a patient in the last 12 months are really strong. The studies looking at objective errors are tough. There's links looking at burnout scores on the care team and mortality ratios for patients on the unit. Some of the strongest data is from nursing units looking at relationships with catheter-associated line infections and the like. So a number of studies there. And then the productivity and turnover data studies, we did a productivity study at Mayo Clinic in which we looked at burnout scores today, predicting whether you independently reduced clinical productivity and work effort over the next 2 years based on your payroll records, and demonstrated that link. And then the turnover data studies from Stanford, Cleveland Clinic, and UCSF showing that the physicians in your group that are burned out today have double the actual departure rate from the institution in the next 24 months. We have done some simulation with leaders from Harvard Business School looking at the economic effects of all of this. And again, just the turnover and productivity elements cost the U.S. care delivery system about $4.5 billion a year, without accounting for any of the quality effects or patient experience effects and a number of other ripple effects on the care team that are just hard to quantify the economic impact. But so I think that all that to say, there's just a really strong business case, if you will, from extensive lines of evidence on how this is affecting our care delivery system.
Yeah, I think that's incredible. And just because, we have an audience that likes to read, you sent me this article. I'll just share it with the audience now, and then I'll put it also in the text of this podcast. But Physician Wellbeing 2.0, it's in Mayo Clinic Proceedings, October 2021. I'll put the links in our chats and such. But, this is a great kind of resource to kind of look at the basic references that you just went over if people are interested in reading more. A couple points you made that I just want to get into a little bit more. And I thought one of the really important things that I think the audience needs to hear is it's not just physicians here, right? You brought up the care team, and outcomes are bad when the nurses are burnt out, when our medical assistants are burnt out as well. And we can unify our team under a cloud of wellness and resilience just as much as we can kind of see things fall apart under the detriments of burnout.
Yeah, it's so true. And what's important for us to think about and give attention to is that the pain points that drive some of the occupational distress, I guess I should say first, of course, we're human beings, and that we are subject to the same emotional mental health issues that can affect all human beings. And that's true for obviously healthcare workers of all types. When we think about the occupational distress dimensions, which include things like burnout and work-life integration and work-related fatigue, moral distress created by the work environment, what is important to appreciate is that which of those is the biggest pain point, and what factors in the day-to-day work environment trigger it varies quite greatly by the type of healthcare worker you are. So a pharmacist has a different daily experience than a social worker or a nurse or a respiratory therapist. And that even within specialty, a surgeon and a primary care doctor and a radiologist have very different daily work. And so when we think about the occupational distress domain, and as we've studied this, what we find is that which domain is sort of the most acute pain point can be quite different. Prior to the pandemic, for example, we saw that the work-life integration domain was by far the biggest struggle for nurses. Whereas for advanced practice providers, burnout was a bigger struggle, and for physicians, both were equal. And so we want to sort of recognize those elements and then the driver dimensions, because I always look at this with my oncologist lens, that we started becoming much more effective in the way we treat human malignancy when we understood mechanistically how different cancers escaped our immune surveillance and had different survival pathways they would activate. And when we begin to be able to identify those and target them, we started having far more effective interventions. And I think here, if we consider an example, we see often that neurosurgeons have by a very large margin the greatest struggle with work-life integration, and actually have had slightly below average rates of burnout. Emergency medicine doctors, sort of the reverse. Due to the shift structure of their schedule, the work-life integration issue less challenging, but exceptionally high rates of burnout. And so that if we think about it, there are certainly some shared dimensions that benefit everyone that we should attend to. Effective leadership, effective teamwork, alignment of values between the individual and the organization. Those things are transcendent. All healthcare workers benefit from them. But then there are other things, mistreatment by other members of the care team impacts nurses more than any other group. Mistreatment by patients, families, and visitors. Nurses bear a greater burden of that. Moral distress issues, often nurses bear a greater burden. Role ambiguity is a real challenge for nurse practitioners and PAs. I get to be a scribe, or I get to be a nurse practitioner today, and tomorrow I'm treated like a scribe, depending on who I'm working with. And so I think that's where we have to take the both and approach of what are the things that benefit everyone, and then what are the things where we need to target some of the specific challenges that are creating the greatest work-related distress for the given group. And so I think that's where kind of moving on both fronts can really help us.
I think that's tremendous. I talk to a lot of young surgeons, and not just young surgeons, but I think one of the biggest struggles for surgeons, and it's good to hear this, that we should maybe expand this line of thought to our nurses and our teams, is identity confusion, right? Often we think we're someone other than we are, or our boss thinks we're someone other than we are, or the institution thinks we're someone other than we are. And when we have those conflicts on who we think we are and what we're expected to be in our work environment, and I think this extends beyond medicine and surgery, I think that's a major source of distress for people. And when they're aligned, on the flip side, it could be a major resource for wellness, is being aligned with who you are and who you want to be.
It's a great comment, Phil. And I think one of the reasons that is particularly acute during training is you're rotating every month, right? And so, and especially the first year or two, it might be your first rotation in this, specific area of urology. And so you're coming up to speed, and it's just, you're a perpetual novice. Every month you sort of feel like you are, starting with a deficit of knowledge. And maybe the second time around, you're feeling you've got a platform to build from. But I think that constant sense of rotating to new hospitals with new attendings, with different expectations in different sub-disciplines, really fuels that challenge that you articulated.
That's right. One of the other things you brought up that I think it's really important is kind of the patient experience and how our burnout can affect this. And I'll bring up a very concrete example. A colleague of mine was really struggling in clinic, was just overworked, overburdened. The template was way out of control. And we sat down and we reconfigured the template, made it a much more manageable day in clinic. And that person's patient satisfaction scores went up 1/4 of a point within 2 months of making those changes. I mean, and let alone that person's happiness and their own kind of reflection on wellness and well-being and burnout. But the patient scores went up, and that was a real eye-opener to me, how quickly that happened as well.
Yeah, I think that's right. And on one level, I think we take a step back and, we say, well, of course that's true, but it's easy to get down in the weeds and miss it. But I use the example of even just in your home life, the people around you, friends, family, when you are tired and, have had a really long week and maybe haven't gotten a normal amount of sleep, and, just what you have to give and your margin and your reserve and your level of patience, your emotional intelligence in reading the situation are not at their best. And I think it's the same when we structure a clinic where it's, just densely packed. There's not time to think. If anything doesn't go, exactly as expected, which of course, there's never a day that the whole day goes exactly as expected. But, things get off and you're running behind, or you're trying to do 2 things at once and people need, more from you in different places. Then you're in the next room and your mind isn't fully in that room, and the patient's not getting all of you. You're reading of their cues and needs, and maybe asking that open-ended question to really draw them in, as opposed to moving through the visit quickly. It's not surprising that we've set things up for a patient experience to be, less than ideal. And so I think you're right that when we take a step back, we can really optimize that. And maybe the last comment I would make on that, I think sometimes we need to consider this in our sort of programs on professionalism or, reporting systems, because we've seen this, that of course there's some folks whose behavior is inappropriate in the way they treat others and interact with teammates that just needs to be addressed. But I think the first question we should ask is this physician experiencing burnout, depression, some other challenge in their life? Have we set up the practice environment in a way that is just making it more likely that they're going to struggle than that they're going to succeed? And that we see that frequently. And again, we have objective data that says for a whole population, your burnout score today predicts your unsolicited patient complaint score, which is a strong predictor of malpractice suits and also surgical outcomes. And so we have good evidence to say that that should be our first question. And I think some of our leaders in that office are trying to think about, and have done, I think, some incredible work in some instances of, just as you said, that met with the person, did identify that they were struggling because of just unrealistic productivity expectations in the clinic, and actually changed their template, made it less dense, added some additional support team. And it was a win for everybody, right? Rather than this person going on discipline or even exiting the institution, we were able to keep a highly talented person and create an environment where both they and their patients were set up to succeed.
I think that's hugely important and really nice to hear. You know, we talk a lot on this podcast and around about being mindful and being present. And that's how we get, you know, the great interactions with our patients. That's how we really take good care of them, by being present, whether it's in the clinic or the operating room, and being mindful. But sometimes it's hard to do that as an individual. And so we have to think institutionally, how can we support that? And what can we ask of our institutions to help us support kind of a mindful present practice?
I think that's right. And I think all of us can and need to get better at optimizing the individual parts of that, because even in an ideal optimized practice environment, the work we do is sort of three things at once and emotionally demanding and so forth. And if we aren't training, teaching ourselves to when the door closes, to be in the room with the patient, to be fully present in that room, it will never maximize that encounter. But by the same token, that there are things that the practice environment does or does not do that makes the difficulty level for the nurse, the physician, the people caring for that patient to do that more or less difficult. So I think we really have to attend to both, because we have some studies where we've looked at resilience scores in physicians relative to workers in other fields. And I again, don't think anyone would be surprised that we've found that physicians are more resilient than people in other occupations. We wouldn't have survived our training were that not true. Certainly amongst the physicians, as you move from lower to higher levels of resilience, your burnout risk went down. So we all want to strengthen that. But I think what was also really compelling is that in the people who had the highest possible resilience score on the instrument used in that study, they had maximized, they're hitting their head on the ceiling, that 30% of them were still burned out. And so it just does show the notion that, a bad system will beat good people every single time. And no matter how resilient and mindful we create the individual to be, a bad system can still beat that person. And so that's where we have to sort of embrace working on both.
Yeah, I love that. A bad system will beat a good person every time. I think that's a really important message for leaders and people to understand. I'm going to ask you, you mentioned burnout scores, and they predict kind of attrition at 24 months.
Yeah.
So does this tell us as an institution, and I'm extrapolating here, do we have a 24-month clock when we encounter somebody who's burnt out? How do we work with the individual, when we recognize or think that somebody's burnt out?
Yeah, it's a great question. So I'm trying, there's a couple ways we can come at it, right? We can come at it from so the individual, and then we can also come at it from the system. I would say, do we have a 24-month clock? Probably not. And the reason I would say that is it's affecting quality of care today. It's affecting patient experience today. Although the risk of turnover is double, some people who are burned out will stay because of their kid's a junior in high school and they can't move them until they graduate, right? Or their partner's career really makes them feel that they have to stay. And so, again, it doubles their risk of objective departure, but some of them will be around for a while and have suboptimal, outcomes. So, and some of them will leave sooner. So I think we should treat it as something we respond to with alacrity when it is identified. Now, what does that mean? And I love, again, the example you created. And I think as leaders, if it's a person in, my unit and that I'm their leader, we need to probably do more than just connect them to our psychologist or connect them to a coach. Those things are helpful. But we also need to say, what really were the variables that contributed to this? And are there things in the work environment that we need to adjust, at least temporarily, while we are focused on, some restoration? and then sort of re-engineer over the longer term. So I do think on a national level, we're already facing large shortages of physicians. And increasingly, healthcare employers are recognizing that they're going to have a struggle to maintain an adequate physician workforce, and that we don't want to lose people for the wrong reasons. And, again, if you're from, Miami and you're moving from Philadelphia to Miami because you want to be back with the family, that's different than you're leaving because it's you're running away from a broken system that burns you out.
Yeah, it's a very, very, very fair point. And so I love the concrete kind of thoughts you gave there about helping the individual, psychologists, coaches, addressing both temporary and permanent changes to the practice are certainly things we can do. Now, talk us through your role a little bit as an institutional leader and how the institution thinks about these things, not necessarily at the individual level.
Yeah.
So how should we be thinking about it?
It's a great question. And, as far as a healthcare focused chief wellness officer, Stanford really established that role in 2017 as the first large academic center to create that type of position. And there are now 40 to 50 of us. So about, one or two additional institutions are creating such a role monthly. And what I view that position as, in part, is to imbue the well-being of clinicians into all organizational decision-making. Much the way that you might think about the chief quality officer, that yes, they are leading a team and they're leading some interventions, but beyond that, they're sitting at the table with the CFO and the COO and the CEO and the chief medical officer, chief nursing officer, all others, and making sure that every decision we're making as an organization is considering the impact that decision might have on quality of care, or how quality should influence that decision. And I think that this is the same circumstance, that in every major organizational decision, we should be thinking about what's the impact of this on the well-being of our clinical workforce. Because if we unwittingly ignore that and damage that, it will have all sorts of other implications that undermine what we're really trying to accomplish. So I think imbuing that in all decision-making is really critical. I think also helping create at the organizational level a mindset of distributed ownership. Every chief, every chair is responsible for this as one of the things that they, as a leader, need to attend to. How do we help them see the value in that? How do we help equip them to be effective in that? And so I think that there are some of those elements, that there are some system level broad things that we need to work on in the culture or that benefit everyone. And then I think the other main task is, how are we also working on identifying the unique needs for the urologist, for the radiologist, for the hospital-based nurses or the outpatient-based nurses, whatever group you are trying to support. And so that we're also sort of optimizing those local work environments. And how do we create the structure and process to sort of move toward better outcomes in those domains for each unit? And that's a complicated thing to think about. And again, the quality infrastructure is the best analogy, right? That the chief quality officer and the team in the quality department probably don't know anything about urology and what the opportunities, where there's something that could be optimized to improve outcomes for your patients. And so often what that team is doing is they are experts in improvement science. And so they would partner with a designated person in the department, and that group would identify, prioritize the project, and then work in partnership with the expertise of that improvement science leader to drive change. And I think this is very much the same, that, you know, our team is small, but we have a sort of a battalion of folks distributed now within each unit who assess their local situation, seek feedback and input from the local group. That group prioritizes the local project with their leader, and we support them in the execution of it. So I think that in aggregate, that sort of system level role is both elevating this to a core priority to the institution. We've got to assess it, so we've got to have a way to measure it. We've got to introduce it into all our thinking about all key decisions, help all leaders view it as their role and responsibility, including administrative leaders throughout the whole chain. And then even as we work on the broad pain points, we have to get at those unit-specific things that are what are the day-to-day friction point that differ for urology and pathology.
That's great. I think this concept of distributed ownership is so powerful, right? And the example is set by leadership at the highest levels, but it really does need to trickle down and be a part of everything we do. And I love your analogy to quality, but we also see it in the DEI space now, right? That we really need to set examples at the top, but work through every level of improving wellness, improving our diversity and our inclusion, and being inclusive to others. And on the flip side, we can help foster the upper levels of the institution by building it at the grassroots level.
I think that's really true. And, you know, diversity is exactly the type of example, because everybody has to look in the mirror and own that. And at the higher levels of the organization, we have additional responsibility and accountability, but all of us have to own it if we really want the institution to make the progress that we know our institutions need to make.
Yeah. Ask you a little bit more down a personal vein. Has this work helped you with your personal wellness?
I think it has. It's certainly forced me to reflect. You know, oftentimes we're studying things and identify something new, and then you're saying, gosh, where do I see this in my own experience as a physician, or as a, person in healthcare, interacting with your own family or outside of work. And I think there's also an element of just having to be accountable in attending these things in my own life. I definitely try to establish boundaries more. I am far more attentive to things, even just like my own sleep, far more attentive to self-evaluation, self-compassion for just my own experience as something that's matured a great deal over the arc of my career, largely through things we've learned, people I've interacted with, colleagues who I admire, who are really have taught me a great deal.
I think one of the things we struggle with wellness is we want to give people the foundations and the basics. Like you just talked about sleep, nutrition, right? Physical exercise. But as an institution, if we send out a PowerPoint or something that you need to look at over 5 to 7 minutes, that's the number one complaint is, oh, now it's just another module I have to do. And so it's the balance. How do we, institutionally versus, we can't afford a coach for everybody either, which would be amazing. But how do we get there?
Yeah, it's a great question. And I think the other thing that's tough is, although we all do have control over some personal decisions that can impact our wellness, and yet it's 80% system. So I always say that the part we're talking about is 80% system, 20% individual. That doesn't mean we should neglect the 20% that's ours. And yet, I think understandably, when we talk about things that fall into that area, sleep, self-compassion, self-awareness, various, self-care activities like exercise and the like, people appropriately react because they recognize that you're focusing on what's the minority of the problem. And you're really, in a sense, making me feel like you're blaming me as an individual for what is largely a system issue, and who's working on the other 80%. And I think that until we are authentically working on the other 80% as an institution, I think it's the height of hypocrisy to be sending out those individual messages. It's okay for us as professional societies or colleagues or whatever to say, I wish I controlled the levers of your institution. I don't. Here's some things that you can do for yourself that might be helpful. But when the institution is sending out those messages, it just does not work. So as the institution, we have to go first, if you will, and demonstrate that we are authentically trying to work on some of those characteristics that contribute to the 80%. And then we can say, and here's a portfolio of individual support resources we've established, because we know that it's hard as a healthcare worker with extreme time demands to attend to some of these things. If you are interested in doing it, we want to make it as easy for you to do as possible, but we're focused over here on the 80%. And I think then people are far more willing to say, okay, I'm willing to take on some of these things because you are demonstrating sincerity in that other part. But that is a tough road to walk. I think what goes into that portfolio of the 20% can be, many things. I think it's essential we have the safety net. No matter how optimal the system is, there's always going to be a proportion of healthcare workers that need the safety net, because, you might be doing great today, and then something goes wrong in the case today and a patient has an adverse outcome. And even if it wasn't due to a mistake, it was something that's an acceptable side effect that can't always be predicted, a drug reaction, idiosyncratic drug reaction, you are still emotionally impacted by that in a tremendous way. And so even when the system's optimal, we need that safety net. So peer support, low barrier, psychologically safe, ideally 24/7 free psychiatric or psychologic support. We do offer coaching to all of our employees at Stanford. Not all of them will take you up on it. And so I think you can, often offer it at least at reduced cost, and make that available broadly. And then some of the opportunities for community and connection with peers, bringing groups together, can go a long way. A lot of other things, you just see what's going to work for different segments. The literature and medicine group works for many. Others want to create a hiking group. Others want to, do other things. But I think that creating sort of a portfolio there and providing people options, or even giving them ideas and letting them foster small activities within their own department with people they know, those are worthwhile activities.
Yeah, absolutely. And I think you bring up a good point that, this is highly individualized, and you've got to find what works for you. And people have heard me say this before on the podcast. Listen, I'm into mindfulness and yoga, and I play basketball, and I recognize that combination is not going to work for the vast majority of people, and that's okay. But that's what works for me. And I think what's really important is what you're saying, having this conversation that it's okay to do these things. You should be doing these things. And for a long time in medicine, we didn't talk about these things. It was shunned to talk about these things. Talk about medicine, talk about surgery, and keep everything else kind of out of the hospital. And I think we're recognizing that that's how we get to, well-being 2.0, as you talk about in your piece and your thoughts.
I think that's right, Phil. And where I hope we're evolving to is that sense of that we're always human beings who are doctors at all times. That is who you are when you're at work. And even when you're not at work, you're still a human being who is a doctor. And that professional part has so influenced your experience and your window of insight into humanity and the lives of others. And, just, I think, can deepen our connection to our humanity and And so I think we're always both, in that ability to bring some of that into the hospital with colleagues and be authentic and vulnerable. And that the fact you play basketball doesn't mean you're not dedicated to being, the best urologist that you can become. And then also, I think being able to share our imperfections, our vulnerabilities, our struggles with our colleagues is also something that's really powerful, because oftentimes nobody can quite understand, the challenges you deal with as a nurse, unless they're another nurse, or as a physician if they're not a physician, or sometimes even as a urologist for you or oncologist for me, if it's not someone who does some work that's at least quite similar. And so the ability to have those honest conversations of, when we're not at our best or when we're struggling a bit, the support we draw from our peers is incredible. It's probably the best support that there is. And we need to sort of move away from that mindset that we have to always project that we have it all together, and that what we show our colleagues is, the veneer of the perfect doctor, who might be great at work and have a lot of struggles outside of work. And the people you're working with are having some of those same struggles, and we can support each other.
Well, thanks for saying that. I want to spend the last few minutes, if we can, talking about your concept of well-being 2.0. So I'll try and summarize quickly for the audience, but then give us kind of your update on this and where we stand. So anybody interested in Dr. Shanafelt's kind of thoughts and pieces, the concept is that we evolved or are evolving from an era of distress where where physicians were kind of deity-like in nature, and we were very performance-based. Self-care was minimized, and we've progressed a little bit into well-being, which we call well-being 1.0. We're now, there's still hero-like qualities to being a physician and surgeon. We are a little bit more aware of wellness and work-life balance, but we're not quite at what you call well-being 2.0, where this is kind of integrated, where we're human, where we express human qualities with each other, and we're fully integrated in not only our vulnerability but our growth together. So I hope I summarized that appropriately, but give us kind of your thoughts and take on it, and your newest.
Yeah, no, I think you captured it well, Phil. And at the individual level, I think those are some of the elements of being human, not sort of holding ourselves to unrealistic standards of perfection, which we might uphold in a given case or even, a month, but we can't really uphold it for a career. So how do we sort of reframe of commitment to excellence and growth mindset, self-compassion, community, reconnect the meaning in work? I think we've all been, so many of the changes in the care delivery system and productivity-based payment and incentives and attention to so much minutia has often distracted us from the things that bring us meaning in our work. So sort of recentering on that. I think and then that the ability to be authentic and vulnerable with colleagues is key. The other part of the 2.0 is the journey for the system and the organization. And I think, there we have sort of been on this journey from a lack of awareness to now this great awareness of this issue, but not enough action. And so we really transition to that system level action and focus on not just treating distress, but trying to prevent it. And beyond that, to cultivate professional fulfillment for our healthcare workers. We sort of move to this mindset of a shared responsibility between the individual and the organization. And the last thing I'll touch on too is having more of a mindset of partnership with healthcare administrators and operational leaders. And I think we went from an era where we largely functioned independently 30 years ago to the last 15 years where there's almost an animosity, friction, a lot of finger pointing, reciprocal scapegoating, blaming the administrators for all the problems we deal with. And what we need to move if we really want to change the environment is to a framework of collaboration and partnership to address those issues. And so I think that that's another shift we need to make, because where I see organizations that have made truly transformational change and are really making gains in that 80% area is when the physicians and the administrators come together, both acknowledge this importance, say, maybe we can't do everything right now, but what are the things we can do now? And let's start there and keep building and evolve the practice environment. So I think those are some of those elements. And I always, in the piece, there's sort of a call to action for different groups. And so I think, what are the things we as organizations need to do, we as leaders need to do, and then we as individuals need to do. And I think all of us are individuals. I would suggest that probably all of us as physicians at least are leaders, because even if you don't have a formal title, you're leading a team every day and really setting the tone in the clinic. But so I think we need to attend as leaders to the behaviors of leaders that promote well-being in their team. We have a piece called Wellness-Centered Leadership. That's another one that really talks about universe being a broad domain of skills, but which skills are most critical for the well-being of the team. We need to foster those relationships between team members and make sure we are aligning the work of the unit with really the altruistic values that healthcare professionals hold. And then as individuals, it's really about rejecting the role of victim, stop blaming administrators, being part of the solution. We're not powerless, attending to the self-compassion domain, because I think that is our Achilles heel as physicians. We're compassionate with others, but perfectionistic and self-critical. Prioritizing our relationships and personal needs, and then committing to supporting colleagues and creating that culture of vulnerability.
I think that's huge and very well said, Tait. One of the things that's helped me as I've climbed up and developed more administrative roles and tried to have a more mindful and thoughtful approach is recognizing the strengths and weaknesses and honoring what our administrators do. I've picked up more administrative roles, and I could tell you, I would be very unhappy if I was a permanent administrator and did not have a clinical role. So it's helped me to really honor the people that have taken this on and taken on this challenge of purely administrative roles in the hospital and how challenging that is. But at the same time, recognizing that they come at it with a different angle than we do. We're almost always focused on patient care or some patient care outcome. And they're entirely focused on keeping the lights on and the doors open. And there is synergy there. Ultimately, it's an altruistic goal, but we come at it from different angles. But instead of kind of conflicting over it, recognize where we can work together. It's helped me tremendously. And the good administrators I've worked with, I think, see the same way.
I think you're spot on, Phil. And we're in the midst of a qualitative study right now, interviewing both physicians and administrative leaders, and both understanding some of our misperceptions about each other. But one of the things that I think is quite interesting is that healthcare administrators are not in healthcare by chance. There's a reason they're not at Merrill Lynch. And they often chose healthcare for many of the same altruistic reasons that healthcare professionals did, of why are they an administrator in healthcare as opposed to tech or industry. And so that's where, again, there are things we see differently, no doubt, but we have many shared values. And I think recognizing that, building from that place, gives us a much greater opportunity to have conversations about some of the things that need to change and what's possible.
Yeah. And I think sometimes it helps to, when you're in those meetings, concretely saying, hey, I'm thinking about it this way. How are you thinking about it? And I think bringing that out in the open helps people understand shared perspective and differences.
Yeah. Yeah.
So Tait, I want to be respectful of time. We're coming up on an hour. I wanted to give you an opportunity. Is there anything you wanted to talk about that we didn't get a chance to cover, over the last 45 minutes or so?
I don't think so, Phil, other than to say, I hope that we can all embrace being the change. And I am optimistic, although we have a long way to go. When you really look at the arc of where we were 20 years ago and where we are now, there has been progress. It hasn't come fast enough for any of us. But the conversations that are being had now, I think the recognition on organizations of the importance of this domain has never been greater. There are substantive efforts by the National Academy of Medicine to engage payers and regulators and accrediting bodies to do more about this dimension. Our Surgeon General has prioritized this as one of his key actions and is releasing his national plan around this, as is the National Academy. So there's good things happening nationally. And I think we as healthcare workers, and I'll say as physicians specifically, I really believe that there's little that we can't change if we prioritize it and work collaboratively with our colleagues to advance something. And so I think if we are working with our administrative colleagues in a solution-based approach rather than just bringing complaints and pointing fingers, there's a lot that we can do. And so I hope that folks will say, I'm going to optimize the unit in which I work, and I'm going to, start there. And what we often see is that once there's a little bit of momentum building, it can start to accelerate and others copy it, and that it starts spreading across units when people see what one team is doing. And so I think we can all start wherever we are going to work today.
That's amazing. I want to ask you one very concrete question before I get kind of into the summary, but I just want to say, one of the great joys of doing this podcast for me is getting to meet great humans and great physicians like yourself, and seeing different perspectives and seeing how we can influence each other and be the change. But I also want to thank you for making this a recognized and established academic kind of endeavor. And so for people out there listening who may be interested in, this is just turning on their academic wheels, whether they're in academic instances or they're in big private practice groups or whatever they may be, how do they start out on kind of projects here and academic kind of interest? What's the funding mechanisms? How do people kind of get started here?
Yeah, it's a good question. So I think the first thing I would say is approach it the way you would other science, in that make sure you're defining the problem well, or if that's the project, think about how you're going to define the problem well. And then what's your hypothesis, and then structure whatever you're going to do in a way that allows you to test that hypothesis. So if you're thinking about an intervention or a change, how have you really defined the state before, and what you're defining a concrete intervention that perhaps others could replicate, and then measuring impact well. I think a lot of the tools from improvement science and quality improvement apply really well. So if that's not your field, partner with someone in that arena, because those most of our institutions have good quality improvement leaders. So that can be a real assist for you. And I think that where the field is in greatest need still, understanding all the implications of how distress, or at the other end, professional fulfillment, can impact the work of a given discipline or specialty, urology. We have more to learn there, and that sometimes builds the case for different types of interventions specific to urologists. But I also think that the field is largely at a place where we need more rigorous evaluation of interventions, that people are aware of the problem. Everyone wants to do something about it. There's a lot of great ideas, but not all of our good ideas will turn out to be effective. And so all of us are looking for our peers to implement and then test and say, this was a great idea, but it didn't work, and you've saved me from going down the same road, or at least going down that same road in the same way. Or to say, this was our idea and it actually worked, and now we can just adopt that or take that evidence to our leaders to say, we do need a additional team member to play this role, and here's the evidence for effectiveness. So I think that those are maybe the arenas to think about of rigorous evaluation of interventions.
I love that. Thanks, Tait. So it's been a great hour. It's been a wonderful conversation. I think a lot of people are going to benefit from this conversation, particularly understanding the perspective of the institution, where a lot of people do like to point fingers. And so understanding that our institutions do have our interests at heart and kind of working together is how we're going to move forward. So I think one of the major themes from today's conversation was kind of the both end approach. And it came up a bunch of times. Physicians are incredibly resilient, but vulnerable, right? And recognizing that and talking about it is okay. We talked about, kind of the human aspect of being a surgeon, being a physician. We talked about all of the ways that occupational stress can affect outcomes, whether it's quality outcomes, the patient experience, productivity, and turnover, which was a huge conversation. We talked about mindfulness and how these things can prevent us from really being present with our patients, whether it's in the clinic, whether it's in the operating room, or whether it's in our other endeavors. And we talked about distributed ownership, how we get a distributed ownership both at the institutional level and scaled down to our individual practices and our individual lives. And lastly, I thought really powerful is that we are all human beings and we are all doctors. I think that's an incredibly powerful message that everybody needs to hear and take time to think on and how that influences our lives and who we are.
Thanks, Phil. I really enjoyed this and great to be with you today.
You too, Tait. Take care.